Hello everyone, welcome back. So today we are going to continue ECG. In that, today we are going to discuss two things: axis deviations, that is left and right, axis deviation, and WPW syndrome. Okay, so what is axis of the heart? So axis is actually average average of electrical activity of heart. Okay, so basically we cannot do all the complexes, so we'll take one complex whose direction of electrical activity will decide the axis of heart, that is QRS. Okay, so QRS complex is used to see the axis of the heart. Okay, now these two diagrams see properly. So as you can see, the normal axis of the heart. Okay, so what is QRS? QRS is a depolarization that starts from the SA node and goes to the apex and towards the returns towards the base. That's what we have discussed in the previous videos. Okay, so this is the direction of the depolarization. Okay, so as you can see, QRS goes in the direction of it goes first inferior and then it goes to the left. So remember two things, inferior and left. So as you can see, this is left side and this is inferior side. Okay, so it is between this two axes. So between AVL and AVF. Okay, minus 32 plus 90 degree. Okay, so in to decide the axis, this four leads are used. But typically we use lead 1 as for the left side and lead AVF. Okay, as simple as it can get. Now as you can see, left axis deviation. So for example, there is a left ventricular hypertrophy. Okay, whenever there is left ventricular hypertrophy, already QRS is on the left side and inferior side, because left ventricle is normally also predominant over right ventricle. So for example, if there is LVH, so this will increase and its contractility will increase. So obviously there will be predominance, increased predominance over the left side. So it can lead to left axis deviation. So what is left axis deviation? It is between minus 30 to minus 90 degree. Okay. So now as you can see, between this minus 30 to minus degree for AVF, this is actually on the opposite side. Okay. So AVF QRS will be negative. Okay, as you can see, this left axis deviation and AVF are on the opposite side. Okay, so for AVF, QRS will be negative. Okay, and as you can see, left axis deviation is near lead 1. So for that, depolarization wave is actually going actually near the lead 1. So the QRS complex will be positive. Okay, the easy way to remember this is left leaves. That means left QRS complexes, like between 1 and AVL, is leaving each other. Okay, so that is how it should be remembered, but you have to understand the concept about it. Okay, for right axis deviation, okay, if there is right ventricular hypertrophy, so obviously it becomes abnormal. Normally left ventricle is more predominant than right ventricle. So whenever there is RVH, okay, this is just one of the examples, we'll discuss the other causes also, but whenever there is RVH, okay, RV contractility increases and there is RV predominance, so it leads to right axis deviation. So right axis deviation is between 90 degree and 180 degree. Now as you can see, for this right axis deviation, okay, for example, this is the direction of the axis of the heart. Okay, so as you can see, for this lead AVL is on the actually opposite side. Okay, so for that lead 1, sorry, for lead 1 it is an lead 1 and AVL, it is on the opposite side. So in lead 1 QRS will be negative. Okay, and as you can see, this axis is near lead AVF. So for AVF it will be a positive QRS. Positive QRS means what? It is a depolarization. So whenever there is right ventricular hypertrophy, there will be predominance of right ventricular depolarization seen on the ECG. So AVF will show positive and one will show, so this is what we call right reaches. Okay, now as I told you, normal depolarization axis is going down first and then left side. Okay, so what happens for the normal axis? So both will be positive because it is going down, so AVF is near it, and as it is going towards left, AVF will also, one also will be positive. So both has to be positive. This is normal axis. Got it? I hope this is clear. So how do we just revise it. Okay, for normally it goes inferior and on the left side. Okay, inferior and on the left side. Okay, so inferior lead is AVF and left side is lead 1. Okay, so for both of them it will be a positive QRS wave complex. For left axis deviation, AVF is opposite to the axis. So AVF will have negative QRS because the depolarization positive wave is going against AVF, and for lead one, it will, because the depolarization positive wave is going towards lead one, it will be a positive QRS. How to remember? Left leaves. Okay, for right axis deviation, as you can see, depolarization wave, positive wave is near lead AVF, so AVF will be positive, and it is going against or opposite to the lead 1 and AVL, so they will be negative. This is how we remember right reaches. Okay, so I hope this is easy to remember for you guys. Okay, now what is this? So you have to see two leads only for axis. Lead 1, this is lead 1. Okay, this is lead 1 and this is lead AVF. So as you can see, the QRS complex in lead 1 is in negative and in AVF it is positive. So this is right axis deviation. Okay, this is right axis deviation. Right reaches. I've already explained the mechanism of it. Okay, so as you can see, this is positive and this is negative. Okay, now we'll discuss the causes of RAD, that is right axis deviation. It can be a normal variant. It can be seen in inspiration, which is again normal. Inspiration leads to decreased intrathoracic pressure, which leads to increased venous return to the right heart, and right heart will obviously contract more. Okay, then RBBB. So as you can see, this is right bundle branch, this is left bundle branch. Whenever there is a blockage of this bundle branch, left bundle branch will try to depolarize the right ventricle through the IV septum, okay, from left side to the right side, so it can lead to right axis deviation. Okay, then as I already told you, right ventricular hypertrophy, okay, any cause will lead to right ventricular hypertrophy and lead to increased contraction of right ventricle and predominance. It can be seen in lung diseases, whether it can be seen in acute lung diseases like pulmonary embolism or chronic lung diseases like COPD, emphysema. Okay, left posterior fascicular block. So a left bundle branch is divided into two fascicles, anterior and posterior. I have already discussed this in my previous video. Okay, anterior is on the left side, okay, and posterior is on the right side. So posterior fascicular block will act like right bundle branch block. So again it is divided into two parts, and whenever there is right posterior fascicular block of left bundle branch, okay, so again the depolarization wave will go to the left anterior left anterior fasciculus of left bundle branch, okay, and will try to depolarize the right side of the heart, so it can lead to right axis deviation. Dextrocardia is actually heart is on the right side of the body, okay, or of the chest. Okay, so when you put the normal ECG leads, it will be right axis deviation. Ventricular ectopics can arise from either right ventricle or left ventricle, and accordingly it can lead to right axis deviation or left axis deviation. WPW syndrome we'll discuss ahead in later of the slides. Okay, lateral wall myocardial infarction. So whenever there is, this is the lateral wall of the left ventricle. Whenever this is infarcted, okay, the depolarization wave will won't go on the left lateral wall, okay, and obviously left ventricle will contract less strongly, so there can be a right axis deviation. And second, in ASD there are two types, we'll discuss. Okay, so the secondum one leads to RAD, the another one can lead to LAD. Secondum ASD is the most common form of ASD. Now, as you can see, again in this you have to see two leads, one and AVF. Okay, so as you can see, QRS is on the is positive in lead one, and AVF it is negative. So this is left leaves and it is left axis deviation. Okay, left leaves. Remember this, right reaches. This is just a way to remember, but obviously you have to understand the concept. Now, causes of left axis deviation, again it can be a normal variant seen with age, okay, increasing age. Expiration, so inspiration leads to increased blood volume in the right heart. Expiration, so expiration means there is increased intrathoracic pressure, blood from the lung will go to the left heart, okay. High diaphragm can cause the heart can move on the left side and can lead to left axis deviation. Left bundle branch block, again same thing. If this is blocked, the right bundle branch will be depolarized first and will try to depolarize the left ventricle. Because left bundle branch is blocked, it cannot depolarize left ventricle. So the wave of depolarization goes from right ventricle to left ventricle. So that's why it leads to LAD. So remember, LBBB leads to LAD. LVH, again opposite to the RVH. If LVH is there, like in hypertension or aortic stenosis, okay, that can lead to left ventricular hypertrophy, and it can be more prominent than normal and can lead to left axis deviation. Left anterior fascicular block, as I already told you in the previous slide, it is on the left side. Okay, so whenever that is blocked, the wave of depolarization will go to the right bundle branch and left posterior fascicular branch. Okay, so it can lead to this too, and from right side of the heart, the depolarization wave moves towards the left side of the heart and can lead to left axis deviation. Ventricular ectopic rhythm, again same thing. If it arises from the left ventricle, it can lead to LAD. Wolff Parkinson White syndrome, there are two types. We'll discuss. Inferior wall MI. So inferior wall MI, this is the inferior wall. Okay, so remember, inferior wall of the heart or of the left ventricle is supplied by the RCA, right coronary artery. Okay, and right coronary artery also supplies the right wall. Okay, so again same, like whenever there was left lateral wall MI, it was right axis deviation, because left ventricle or the lateral wall of the left ventricle is contracting less prominently. So same thing, whenever there is RCA infarct leading to right wall and inferior wall MI or myocardial infarction, and so this right ventricle will contract less prominently. So obviously there is a predominance of the left ventricle and can lead to left axis deviation. And congenital heart disease like primum ASD. Okay, most common is secundum, but primum, remember, secundum leads to right RAD and primum leads to LAD. And endocardial cushion defect, most commonly seen in Down syndrome, again can lead to left axis deviation. Okay, so what is WPW syndrome? It is a pre-excitation syndrome. Okay, what does pre-excitation mean? So as you can see on the diagram here, so normally the depolarization or the impulse go from SA node to the ventricle through the AV node. Okay, so as I told you in the previous video also, AV node is needed for a proper conduction of the impulse. So whenever the impulse goes from SA node to AV node, QRS complex is less than 120 millisecond. Okay, that is a normal QRS complex duration. Okay, but whenever it goes whenever it goes from anywhere apart from AV node, okay, it will be wide QRS. Remember, this is the concept behind this. If the impulse from SA node to the ventricle does not go from AV node, it goes from any other pathway, it can lead to wide QRS. Okay, it takes more time to, because this is the fastest conduction of the impulse in the normal heart. Okay, so whenever it is not going through the normal conduction pathway, that is AV node, Purkinje fibers, it can lead to wide QRS. Okay, so as you can see, this is the normal conduction and this is the WPW syndrome, pre-excitation syndrome. What does pre-excitation syndrome means? Okay, so pre-excitation syndrome, there is an accessory pathway. Okay, there is an accessory pathway which excites the ventricle before it should be excited by the AV node, the normal impulse going through the AV node. So as you can see, there is this pathway. Okay, this pathway is carrying the impulse to the left ventricle. So before this impulse reaches to the left ventricle, this will excite the left ventricle. That's why it's called pre-excitation syndrome, and there is a wide QRS complex. So whenever there is wide QRS complex, that means the impulse is not following the normal pathway of conduction. This is the concept behind it. Okay, so what do you see in WPW syndrome? So there is short PR. Again, as I told you, it is not, so there is a AV nodal delay. Now in normal conduction, there is a AV nodal delay. Okay, that is needed, as I told you in the previous video, to to atria to contract before ventricle. Okay, to completely empty the atria. So whenever it is not going to AV node, that means there is no such delay. So PR interval will decrease. Okay, as I told you before also, PR interval is the interval or duration of transmission of impulse from through the AV node into the ventricle. Okay, so if it is not going through that AV nodal delay pathway, there will be a shortening of this PR interval, which is normally around 0.12 second. Okay, so that will be decreased. So there will be short PR interval, there will be wide QRS because it is not following the normal pathway. Normal path, as I told you before also, Purkinje fibers is present normal conduction pathway. Those are the fastest conducting fibers. So if it does not follow this that conduction impulse, okay, then it can lead to wide QRS because it takes more time from the normal ventricular myocytes. It takes for the impulse more time to go from the normal ventricles. Okay, so there will be wide QRS and there will be discordant. Discordant means one wave is going up, other wave is going down. So normally T wave is upright. Okay, but there will be discordance between QRS and T wave. This is normally seen. This is secondary STT changes seen in WPW syndrome. Okay, now one more thing I wanted to discuss is there are two types of WPW syndrome. Okay, so one is this accessory pathway. Okay, so this accessory pathway, as there is no AV nodal delay, so this will be always prominent than this. So normally this is the ECG that is present in a patient of WPW syndrome. But sometimes there is episodic tachyarrhythmia in this patient. Okay, there are some conditions, especially whenever there is AV block. Okay, whenever there is this blocks, so this accessory pathway becomes more prominent than the normal. Okay, and the impulse goes through this and causes pre-excitation syndrome leading to episodic tachyarrhythmia. That means increased stimulation of the ventricles. Okay, so it can lead to episodic tachyarrhythmia and patients can present as syncope, palpitation. Okay, all this in arrhythmias can be seen. Okay, now one more thing I wanted to discuss here was there are two types of WPW syndrome. Type A is left-sided accessory pathway. Okay, so this is the left-sided accessory pathway. Okay, as you can see, the left pathway is on the left side. So when it is left-sided accessory pathway, so as you can see, right ventricle won't be contracted, won't be stimulated by this. So what happens is from this left side, it goes to the right side. The depolarization wave or the impulse goes from this through this accessory pathway from the left side to the right side. Okay, and it leads to right axis deviation. And type B is right-sided accessory pathway. This is accessory pathway. It is also known as bundle of Kent, very commonly known as bundle of Kent. Okay, so this bundle of Kent can be on the right side. Okay, so it goes from the right side of the heart to the left side of the heart. It leads to left axis deviation. Okay, I hope I am clear. WPW syndrome is a pre-excitation syndrome because of the accessory pathway present between the atria and the ventricle. It can be type A or type B, and normally it does not always present with arrhythmias. Normally the ECG will look like this. There will be short PR interval because it doesn't pass from the AV node. Okay, there will be wide QRS because it is not passing from the normal conduction like bundle of his Purkinje fibers. Okay, and there will be QRS and STT discordance. Discordance means both are on the opposite direction. Okay, and the pathway, accessory pathway, is known as bundle of Kent. Okay, so now we'll see the ECG. See, this is the ECG of WPW syndrome. Okay, so normally this ECG will be like this, where you diagnose, as you can see, PR interval is very short. Here the PR interval is decreased. It is one two like two small boxes only. Okay, so that is around 0.08 millisecond. Okay, so it is shortened PR interval. As you can see, this is the delta wave. So the QRS, that is prolonged, there is a delta wave seen in, this is a delta wave. Okay, so WPW syndrome characteristically shows there is a slurring of up, it is called slurring of upslope of QRS wave, which is known as delta wave. Okay, very characteristically present in WPW syndrome. There is a wide QRS. Okay, in this T wave is upright, but sometimes there is T wave inversions are present. Okay, and this patients, whenever there is AV block in this patients, you have to understand this thing. Whenever there is AV block in this patient, the accessory pathway becomes prominent. Okay, and it starts stimulating the accessory pathway, starts stimulating ventricles pre-excitation. Okay, and can lead to tachyarrhythmias. Okay, So patients usually present with tachyarrhythmias. Okay. So AV node can be blocked by increased vagal tone or some drugs, antiarrhythmic drugs. Okay. Okay. So this was all about today's video. Thank you so much. If you like and if you learn from my video, please click the like button. Please share and subscribe. Thank you so much.